Welcome back, guys. Now let's have a rapid review of the gastrointestinal physiology. Okay, so first we will be discussing the concepts, later we will be doing the PYQs. Okay, having said that, now look at here the layers of the GIT. You already know it. How many layers are there? There are 4 layers in the GIT. Okay, there are 4 layers in the GIT. What are they? You know, from inside there is mucosa, submucosa, muscularis and serosa. There are 4 layers. Okay, starting from inside there is a mucosa, there is a submucosa, there is a muscularis layer and there is a serosa layer. There are 4 layers. The important points which I want you to know for your exam are, say, in the mucosa, okay, if you concentrate on the mucosa itself, there are 3 further layers present: epithelial layer, lamina propria and muscularis mucosae. Okay, in the mucosa itself there is this muscle layer which is called as muscularis mucosae. Now this muscularis mucosae, it is not involved, okay, this muscularis mucosae, it's not associated with peristalsis, okay, it's not going to have nothing to do with the peristalsis, okay, it's not involved in the peristalsis. Next, what else I want you to know is the submucosa is the strongest out of all the 4 layers, okay, the submucosa is the strongest layer, and in the submucosa layer there is this nerve plexus which is present called as a Meissner's plexus, okay, Meissner's plexus. Okay, what is the function of this submucosal plexus, Meissner's plexus? It is going to helpful for you in your GI secretions. Secretions are due to which plexus? Secretions are controlled by which plexus? The submucosal plexus or Meissner's plexus. Okay, so the next layer, the muscularis layer. Look here. See, in the muscularis layer, there is one more plexus present, which is called as the myenteric plexus or Auerbach's plexus. Okay, myenteric plexus or Auerbach's plexus, what is the function of this? It helps in peristalsis. Okay, it helps in peristalsis. Okay, the contractions. So, contractions are due to myenteric plexus which is present in the muscularis. Secretions are due to submucosal plexus which is present in the submucosa. Next, the next layer is called as a serosal layer. The serosa is absent in the esophagus. This is a recent PYQ. Serosa is absent in which layer of the esophagus? Esophagus does not have serosa. It contains adventitia. That's a total different thing. Serosa is absent in esophagus. That's it. Okay. Having said that, now some important points about the Hirschsprung disease. See, in Hirschsprung disease, what happens is, in one segment of the GIT, let's look at here. See, imagine this is your colon. Let's say this is your colon, ascending colon, transverse colon and descending colon. Ascending, transverse colon and descending colon. See, in this one part of the GIT, okay, in this segment, okay, in this segment, there is no Meissner's plexus and no myenteric plexus. Both Meissner's plexus and myenteric plexus are absent. So, in this segment, don't expect any contractions. Okay, there won't be any contractions. So, this segment is called as what? Aganglionic segment. Okay, why there is no Meissner's plexus and myenteric plexus? Why there are no neurons in this area? Okay, no ganglionic cells in this area. It's because of defect in a process called as a neural crest cell migration. Okay, this is a neural crest cell migration which happens during the embryonic stage. It is a defective. Because of the defect in the neuronal crest cell migration, there is this aganglionic segment present. No Meissner's plexus, no myenteric plexus. Okay, some important points look here. Hirschsprung disease also called as aganglionic megacolon. What is the problem here? See, the main problem here itself is a defect in the migration of neural crest cells, okay, during development. Because of this defect, there is absence of both myenteric plexus and Meissner's plexus. Both myenteric plexus and Meissner's plexus are absent in the last part of the colon, the distal part of the colon. Okay. Next, say this is associated with which syndrome? It is associated with Down's syndrome. It's associated with which condition? Down syndrome. Okay. So, what is Down syndrome? It's a trisomy 21. It's a trisomy 21. Okay. So, the Down's babies, okay, they are going to have many problems. The GIT related abnormality, one GIT related abnormality is this Hirschsprung disease. Okay. Not only that, these Down's babies are also going to have duodenal atresia. Duodenal atresia. So, now tell me, this trisomy 21 Down's condition is associated with which GIT abnormalities? One is Hirschsprung disease can be seen with them and duodenal atresia can be seen with them. Okay. Next, some important points about the GI secretions. See, there are different secretions. Okay, there are multiple secretions happening into your GIT. Okay, multiple secretions like saliva in the mouth, pancreatic secretions, intestinal secretions, bile, gastric acid, Okay, lot of secretions are happening into your GIT. Important point, the maximum secretion out of all the secretions, who is the maximum secretion? It is the acid, gastric acid, and this is the most acidic secretion. Okay, it's the most acidic secretion. The pH, if you check, it will be 1.5 MCQ. The gastric secretion is maximum, and its pH also the highly acidic, I should say, the least pH, not the more pH, it's the least pH, less the pH, more acidic nature, right? So the pH is going to be very less, a highly acidic substance. Then what is the most basic secretion in the GIT? Most of the students will think it's the pancreatic secretions are more basic, but it's not the pancreatic secretions, it's the Brunner gland secretions. Okay, Brunner gland secretions, they are highly basic in nature. If you look at the pH will be 8 to 9. The pH of these Brunner gland secretions is going to be 8 to 9. Now students will have it out, what exactly are these Brunner glands? Brunner glands are present in your duodenum. Okay, Brunner glands, where are they present? In your duodenum. What is the function of this Brunner gland? Brunner glands are mucus producing glands in the duodenum. Okay, the mucus producing glands in the duodenum are called as the Brunner glands. These Brunner glands produce a highly alkaline mucus into the duodenum. So whenever acid comes into the duodenum, these Brunner gland secretions are going to helpful in the neutralization of acid. Okay, they help in the neutralization of acid. Next, maximum water reabsorption occurs in which part? Okay, the maximum water reabsorption occurs in which part of the intestines? See, maximum water reabsorption, this is also a PYQ, it occurs in the jejunum. Okay, maximum absorption of any substance, okay, occurs in the jejunum. Even water is maximally absorbed. I should say not reabsorption, I should say absorption. Maximum absorption of water occurs in jejunum. Okay, but students usually think that it's the colon where maximum water will be reabsorbed. Okay, but it's not colon, it's the jejunum. Next, some important points about the saliva. Let's start with the saliva. You know, saliva is produced by the salivary glands. The three important salivary glands are parotid salivary gland, submandibular salivary gland, as well as sublingual salivary gland. There are the three important salivary glands. Okay, out of which one salivary gland is called as a major salivary gland. The major salivary gland is your submandibular salivary gland because it produces 70% of your saliva. Next, what are the enzymes which are present in your saliva? Okay, what exactly are there in the saliva? See, saliva contains a carbohydrate digesting enzymes called as amylases. What's the name of it? Its name is called as thylline. Okay, thylline are salivary amylase. It's going to helpful for the digestion of carbohydrates. And for the digestion of lipids, there is a lingual lipase. So from where this lingual lipase is coming? It's coming from this Ebner's gland, important MCQ. What exactly are these Ebner's glands? Ebner's glands are minor salivary glands. Okay, they are minor salivary glands. Okay, there are thousands of such glands, minor salivary glands, Ebner's glands are present. They are going to produce this lingual lipase. So the point which I want you to know here is, in your mouth, in your saliva, there are carbohydrate digestive enzymes, there are lipid digestive enzymes, but there are no protein digestive enzymes. There are no proteases in your saliva. Protein digestion will not occur in the saliva. Okay, so what is the major salivary gland? Submandibular salivary gland. Why? It produces 70% of the saliva. Lingual lipase is produced by Ebner's gland. Okay, thylline is also called as salivary amylase, helps in the digestion of carbohydrates. Okay, having said that, now look at the innervation of these glands. See, this parotid salivary gland, you know it, parotid salivary gland. Parotid salivary gland is getting its parasympathetic supply. Salivary glands are like under the control of parasympathetic nervous system, rest, digest, salivation. It's a parasympathetic activity. So which parasympathetic cranial nerve controls the parotid gland? It is the 9th cranial nerve. How I used to remember is, just remember flip the P, it becomes 9. So parotid salivary gland. Okay, parotid salivary gland is innervated by the 9th cranial nerve, that's a glossopharyngeal nerve. The other two, submandibular and sublingual salivary glands. Submandibular and sublingual, they are starting with which letter? S. So S for 7. So 7th cranial nerve. So which parasympathetic nerves? You know there are 4 parasympathetic cranial nerves, 3, 7, 9, 10. 3, 7, 9, 10 are the only 4 parasympathetic cranial nerves. Okay, parasympathetic cranial nerves. So it's the 9th is going to control your salivation, and 7th, okay, 9th is going to control your salivation from the parotid salivary gland. 7 is going to control your salivation of your submandibular and sublingual salivary glands. So innervation also completed. And what else I want you to know is the saliva, it not only contains the enzymes for the digestive activity, it also contains certain antimicrobial things like IgA antibody. Okay, IgA antibody, which is also called as a secretory antibody. It's called as what? A secretory antibody. It is present in your saliva. Not only that, your saliva contains lactoferrin and lactozyme, which are antibacterial in nature. Okay, these are antibacterial in nature. Okay, something good. Okay, so whenever you eat something dirty, which is like contaminated, that should be like, you should take out the bacteria from it. Okay, so that you contain IgA antibody, which can activate the complements. Okay, lactoferrin, lactozyme, these are all antibacterial things. Next, see, saliva, there are some single units were there. Maximum potassium is secreted into which body secretion? Okay, if they ask you, maximum potassium will be secreted into which body secretion? As far as secreted into saliva. But maximum potassium concentration is present in which body fluids? It's the colonic fluids. So colon contains maximum potassium concentration. Maximum potassium secretion is into saliva. Next, some important diseases related to the salivary glands. See, there is a condition in which the salivary gland will be inflamed, which is called as a parotitis, especially the parotid salivary gland is inflamed. So that is parotitis, because of which virus? Mumps virus, belonging to the Paramyxoviridae family. Okay, the mumps virus belonging to the Paramyxoviridae family. It loves to replicate in the parotid salivary gland. Not only that, they also replicates in the gonads. Okay, not only salivary gland, in males these mumps virus will replicate in the testes. In females it replicates in the ovaries. So the baby will be having, if it's a male baby, the baby will be having parotitis with orchitis. Okay, what else I have to teach you regarding the salivary gland? A recent question was there. See, there is a condition in which the salivary gland, okay, are destroyed. Okay, immune mediated damage, autoimmune. So autoimmune destruction of salivary gland as well as lacrimal gland. Okay, both are damaged. Both are damaged. Autoimmune destruction of the salivary gland as well as the lacrimal gland, leading to dry mouth as well as dry eyes. Okay, that is xerophthalmia and xerostomia. Xerophthalmia, dry eyes, and xerostomia, dry mouth. So what is this condition called as? Sjogren's syndrome. Okay, so in this condition called as a Sjogren's syndrome, the patient is going to have dry eyes and dry mouth. Dry eyes and dry mouth, Sjogren's syndrome. So Sjogren's syndrome, these patients will be having certain antibodies in their blood which are called as anti-Ro antibodies. Anti-Ro antibodies. Okay, anti-Ro antibodies are going to be seen in Sjogren's syndrome, which is also a question which I want you to know. Anything else regarding the salivary glands are important? Yes. See, the cancer of the salivary glands. If you have cancer of the salivary glands, okay, the tumor of the salivary glands. Okay, there are two important tumors which I want you to know. One is Warthin's tumor and pleomorphic adenoma. See, these are the tumors of the salivary gland. Okay, these are the tumors of salivary glands, Warthin's tumor and pleomorphic adenoma. Okay. Now, one more thing is there, mucoepidermoid carcinoma. I don't want to go to that detail. Simply remember, there are two tumors which are important for your exam. They will ask you, Warthin's tumor is a tumor of salivary gland. Okay, pleomorphic adenoma is a tumor of salivary gland. Okay. Next, after this, let's discuss some important points about the stomach. See here, this is the stomach. I am taking some small biopsy from your stomach, little biopsy. Now, you know how many layers will be there in the stomach wall? There are 4 layers. Look at here. Here there is mucosa. This is the first layer, mucosa. There is submucosa, muscularis, and serosa. Okay, there are 4 layers. Look at the mucosa. The point which I want you to know is regarding the mucosa. In the mucosa, are you able to appreciate these depressions? Okay, these depressions are you able to appreciate? They are called as what? They are called as gastric glands. Okay, they are called as what? Gastric glands. Now, question is, see, in the gastric gland, if you look at the gastric gland, in the gastric gland, there are the cells present. Okay, there are these multiple different colored cells present. So each cell is going to produce a different type of secretion. Okay, each cell is going to produce a different type of secretion, and they are important for your exam. See, look here, the first superficial cell, okay, the first superficial cell on the top, it is called as surface mucous cell, which was not here. Let's write surface mucous cell. surface mucus cell, which is also called as foveolar cell. Foveolar cell. It produces what? It produces the mucus. It produces the mucus. The surface mucus cell produces the mucus in the stomach. So, the mucus in the duodenum, you know it. Just now we have discussed the mucus in the duodenum is produced by the Brunner glands. Goblet cells produces the mucus in the intestines. Who produces the mucus in the stomach? It's the surface mucus cell, also called as the foveolar cells. Not only those cells, also one more cell which is present little down to it, which is called as a mucus neck cell. Even this mucus neck cell produces mucus. Okay, even it produces the mucus. Next, other cells, parietal cells, it produces the acid in your stomach. Not only acid, it also produces the intrinsic factor which helps in vitamin B12 absorption, important. Okay, the parietal cells produces the acid as well as intrinsic factor. Intrinsic factor helps in the absorption of vitamin B12. Okay, next, enterochromaffin like cells. These are not enterochromaffin cells. Enterochromaffin like cells produce histamine. What is the role of this histamine in the stomach? In the stomach, this histamine will go and stimulate the parietal cells. It will stimulate the parietal cells to release the acid. So, histamine stimulates the acid release. Not only this histamine, one more thing will stimulate the acid release. One more fellow. What is that? Gastrin. So, gastrin is coming from which cells? G cells. So, G cells produce gastrin. Gastrin also stimulates the release of acid. So, there are two stimulus for the release of acid. What are the two? One is gastrin, other is histamine. One is gastrin, other is histamine. There is one more stimulus, third stimulus. I will tell you later. Okay, don't worry. Next, enterochromaffin like cells produce histamine. But if someone asks you enterochromaffin cells, okay, in the GIT, enterochromaffin cells, not like cells, enterochromaffin cells, what do they produce? They produce serotonin. Okay, enterochromaffin cells produce serotonin. Next, chief cells in the gastric gland. In the gastric gland, there are also chief cells which produce enzymes for the digestion of your macromolecules. So, chief cells produce pepsinogen. Pepsinogen will be helping in the digestion of proteins. Pepsinogen will be converted into pepsin. Pepsin helps in digestion of proteins. Next, chief cells also produce gastric lipase. So, gastric lipase digests lipids. Pepsinogen digests proteins. So, what I want you to know here is in your stomach, proteins are getting digested, lipids are getting digested, but the carbohydrate digestion will not occur in the stomach. Carbohydrate digesting enzymes are not produced by the stomach. Okay, that's important. Next, D cells. So, D cells are going to produce somatostatin. Okay, somatostatin. See, when you eat food, you require the acid. When you eat food, you require the acid. So, acid is coming with the help of histamine and gastrin. When digestion is completed, the acid production should be inhibited. Who inhibits that? Somatostatin inhibits acid. Okay, somatostatin inhibits acid release. That's it. Okay, so these are the important cells and important secretions which you need to know in your exam. This mucus neck cell, one important point is this mucus neck cell, it acts like a stem cell. Okay, it acts like a stem cell. So, every day the superficial layers, the superficial mucosal cells, they will slough off. Okay, they are denuded. Okay, they are every day, they are going to be, there is a loss of the superficial layer. So, this mucus neck cells, they will divide and they forms a new surface mucus cells. Okay. Next, here in this slide, what I am teaching you, this is a parietal cell. Okay, this is a parietal cell. I have taught you parietal cell produces what? Parietal cell produces acid. Okay, parietal cell produces what? Acid. So, what are the stimulus for the release of acid? Already I have taught you gastrin is a stimulus, histamine is a stimulus, and the third stimulus is acetylcholine. Even acetylcholine is a stimulus for the release of acid. So, for the release of acid, how many stimulus are there? 3 stimulus. One is gastrin, histamine and acetylcholine. Done. Next, some important points like pharma integrated points. Say there is a condition called as peptic ulcer disease. You know it. Peptic ulcer disease. There is pain in your stomach after eating the food. There is a peptic ulcer. Gastroesophageal reflux. There is acidic contents are getting refluxed. Okay, the acidic contents are refluxed back into the esophagus. So, gastroesophageal reflux. Okay, and one more condition which is called as Zollinger-Ellison syndrome. In Zollinger-Ellison syndrome, there is gastrinoma, a tumor. There is a tumor called as a gastrinoma. This gastrinoma, it increases the acid production. So, finally, at the end of the day, see, in this peptic ulcer disease, in this gastroesophageal reflux disease, in Zollinger-Ellison syndrome, in these three conditions, there is high levels of acid. So, as a doctor, what you have to do? You have to decrease the acid. So, So how can you decrease the acid? I have told you, see, this is called as a parietal cell and this is proton pump. Okay, what is this? This area is a proton pump. Through this proton pump, acids are being secreted. Okay, through this proton pump, acid is being secreted. Now, what you have to do as a doctor, you have to inhibit these proton pumps. So, proton pump inhibitors, okay, like omeprazole, pantoprazole, esomeprazole can be used in the treatment of peptic ulcer disease and Zollinger-Ellison syndrome. Okay, so peptic ulcer disease is gastroesophageal reflux disease, Zollinger-Ellison syndrome. What are the drugs that can be used? Proton pump inhibitors. Right. Next, there are drugs like H2 blockers. Okay, even histamine is one of the powerful stimulus. So, histamine blockers like cimetidine and ranitidine can also be used to decrease the acid. The problem with this cimetidine, it causes gynecomastia. Okay, let me write full form here. It's also important. So, cimetidine causes gynecomastia in the males, Okay, so Zollinger-Ellison syndrome, it's just a patho thing. You can do it in your patho. Next, pernicious anemia. What exactly is the pernicious anemia? Pernicious anemia, it's an autoimmune condition. Okay, it's an autoimmune disease. So what exactly is happening? It's the immune cells. Your immune cells are going and destroying. Okay, your immune cells are going and destroying the parietal cells. The parietal cells are getting killed. Okay, the parietal cells are getting killed. When you kill the parietal cells, what happened to the acid production? Acid levels decreases, and what happened to the intrinsic factor levels? Intrinsic factor level also decreases. So there is achlorhydria, no acid. Okay, there is achlorhydria, acid is not there. And if you check the intrinsic factor levels, they are also not there. So because of the deficiency of intrinsic factor, can you absorb vitamin B12 now? Can you absorb vitamin B12? No. Without B12, what happens? You will be developing a severe anemia, severe megaloblastic anemia. Okay, so vitamin B12 deficiency anemia, megaloblastic anemia. Okay, so that's the problem. Look at here, pernicious anemia, it's an autoimmune disease. It's characterized, I have told you, it's characterized with severe lack of intrinsic factor. Intrinsic factor is not there, even acid is not there. See, what is exactly is happening? There is antibody directed, okay, damage. The antibodies are coming and killing the parietal cells. Now, it is characterized by increased serum levels of gastrin. So, gastrin levels increased. Why gastrin levels are more in this condition? Because, see, it's the HCl, acid gives negative feedback to gastrin. Okay, I have told you gastrin helps in the production of acid. But you have enough amount of acid. When you have enough amount of acid, it will give negative feedback to gastrin. Okay, now in this condition acid is not there, negative feedback is not there. So what happened to the gastrin levels? Gastrin levels will be more. Your body is trying to produce acid by increasing the gastrin, but the parietal cells are not there, gastrin levels will be high. Okay, next. Sir, in this condition, look here, this is the stomach. Okay, this is the stomach which was opened. It looks like brain, right? It looks like gyre and sulci. Okay, it looks like the gyre and sulci of the brain. Elevation, depression. So this condition is called as Menintrier's disease, which is an image-based question in your exam. So what exactly is happening in this Menintrier disease? The foveolar cells I have taught you. The foveolar cells are the mucus-producing cells in the stomach. The foveolar cells have undergone hyperplasia. Okay, foveolar cell hyperplasia. Okay, it can be seen in patients who are having severe peptic ulcer disease. In this Menintrier's disease, what exactly is happening? Cerebriform appearance of the gastric rugae. The gastric rugae, they are appearing like a brain, like a gyre and sulci. So that is Menintrier's disease. Okay, so in these patients, the TGF alpha levels are going to be more in this patient. The TGF alpha levels will be more in these patients. If you check the blood, the TGF alpha levels will be more. Okay, next. What else I want you to know is, sir, in the stomach I have taught you which digestive enzymes are there? Pepsinogen, gastric lipase. Pepsinogen helps in the digestion of proteins, gastric lipase helps in the digestion of lipids, but there are no enzymes for carbohydrate digestion. No enzymes for the carbohydrate digestion in the stomach, no enzymes for the protein digestion in the saliva, no enzymes for the carbohydrate digestion in the stomach. Now, see, I have taught you pepsinogen is produced by chief cell. Pepsinogen is produced by the chief cell. Gastric lipase is produced by the chief cell. Pepsinogen is an inactive thing. It's an ogen. It's a ogen means inactive. So pepsinogen need to be converted into active form, active enzyme, pepsin. Who is going to do that job? Acid. The acid coming from the stomach. The acid coming from the stomach is going to convert the pepsinogen into pepsin. Okay. Next, substances with a fast gastric emptying. Imagine yourself eating a carbohydrate rich food. Okay, I am eating carbohydrate rich food today. Or let's put it this way. Now, when you take the carbohydrate rich foods, the carbohydrate foods will stay in your stomach for very little time. The halting time in the stomach is going to be very less. If I eat carbohydrate rich food, this food is going to stay in my stomach maybe for the next 4 hours or 5 hours. Okay, hardly let's take 4 hours. Okay, but if I take protein rich food, it's going to stay in my stomach for 6-7 hours. If I take fat rich food, it's going to take a lot of time. It is going to stay in my stomach for 9 to 12 hours. So carbohydrate rich foods have fast gastric emptying, means they will stay in the stomach for little time, then they will go into the duodenum, the food will be digested and glucose will be absorbed. So carbohydrate rich foods have fast gastric emptying when compared to proteins, when compared to fats. You can say 4 hours, 6 hours, 9 hours, something like that. Okay, so don't confuse what is gastric emptying. Gastric emptying means the movement of food from the stomach into duodenum. Okay, from the stomach into duodenum, gastric emptying. Okay, now one important hormone which I want you to know, who delays the gastric emptying. Who delays gastric emptying? So let me write it here itself. Gastric emptying. Delayed by. Who inhibits the gastric emptying? Who delays the gastric emptying? Number 1 is secretin. Secretin, cholecystokinin, okay, cholecystokinin and amylin. Okay, these three. So secretin, cholecystokinin, amylin, they delays the process of gastric emptying. But who promotes the gastric emptying? The gastric emptying promoted by gastrin. Okay, so these are some important points which I want you to know regarding the gastric emptying. Next, the phases of the gastric secretion. Say the acid in your stomach will be produced in multiple phases. For example, right now I am thinking about the food. Okay, I am just thinking about the food, or I am looking at the food, or I am smelling the food. Okay, I am talking about the food, means even if you think about the food, some amount of acid production will start to happen in your stomach. How much acid production? That is called as the gastric phase of acid production. In gastric phase of acid production, there is 30% of acid that is getting produced. 30% of acid will be produced during gastric phase. First phase is called as a cephalic phase, means in your brain. In a cephalic phase, 30% of acid will be produced just by thinking about the food. In gastric phase, 60% of the acid will be produced in your stomach. Okay, 60% acid will be produced in your stomach. Next, in intestinal phase, look, in intestinal phase, only 10%. Okay, so when you think about the food, 30% acid will be produced. When you eat the food, that is gastric phase, when you eat the food, 60% acid will be produced. When the food is moving into the duodenum, okay, when the food is moving into the intestines, the acid production gradually decreases to 10% intestinal phase. Okay, next, the important substances and their absorption site. Iron, okay, that too in only in Fe2 plus form. Iron will be absorbed in duodenum. Vitamin B9, that's a folic acid, will be absorbed in jejunum. And vitamin B12, the cyanocobalamin, will be absorbed in ileum. So, if there is any problem with the ileum, if there is any problem with the duodenum, then iron absorption will be affected and B12 absorption will be affected. For example, look at here, there is a fish tapeworm. This fish tapeworm, which is called as a Diphyllobothrium latum, where it lives in ileum. So, it interferes with the absorption of vitamin B12. Okay, it's because it's living in the ileum, it causes the inflammation of ileum, ileitis. So, the vitamin B12 absorption will be hampered. Now, if you look at here, this worm which is called as Ankylostoma duodenale, in the name itself it is there, Ankylostoma duodenale, it lives in duodenum. So, it interferes with the iron absorption. So, the patient is going to have iron deficiency anemia. Okay. So, Diphyllobothrium latum is going to cause B12 deficiency anemia, Ankylostomia duodenale is going to cause iron deficiency anemia or the microcytic anemia. Okay, iron deficiency is going to cause a microcytic anemia, right? You already know it. Okay. Next, some more important points about the iron. Look at here, guys. Iron. Okay. See, which form of iron will be absorbed? Only Fe2 plus form of iron will be absorbed. Okay. See here, which form of iron is going into the cells? Fe2 plus form of iron. Only you can absorb Fe2 plus form of iron. If you eat plant things, okay, the things which are coming from the plant, you will get Fe3 plus form of iron. Okay, you will get actually ferric form of iron, Fe3 plus form of iron if you are a vegetarian. But in your stomach, the Fe3 plus will be converted into Fe2 plus with the help of acid. Acid is going to convert, the highly acidic substances are going to convert the Fe3 plus form of iron to Fe2 plus form of iron, and Fe2 plus form of iron will be absorbed with the help of divalent metal ion transporter 1, DMT1. Okay, so there is a transporter called as a DMT1 which is present in the duodenum or duodenal enterocytes, which helps in the absorption of Fe2 plus form of the iron, which is called as a ferrous. Fe3 plus form of iron is called as a ferric. Okay, once you absorb the iron, look, this iron, it is coming out of the enterocytes. It is coming out of the enterocytes, it is going into the blood. While it is going out, it is going through a transporter called as a ferroportin. So, entry via the DMT1, entry into the cell with the help of a DMT1, and exit with the help of a ferroportin. Okay, ferroportin. Now, once it comes out, this iron, look, Fe2 plus, it is again further converted back into Fe3 plus form. Okay, the Fe2 plus form of iron is converted back into Fe3 plus form of iron with the help of a substance called as hephaestin. Okay, so now again it gone back to Fe3 plus form. Now tell me, this Fe3 plus form of iron, where it is? Now it is in the blood. Now it is in the blood. Now it is Fe3 plus. 3 plus means it is a free radical. It is having charges. Fe2 plus, 3 plus, these are all free radicals. You should not keep the free radicals alone because they will cause a lipid peroxidation, membrane damage. Okay, so that's why this Fe3 plus form of iron is now bound with a plasma protein which is called as plasma transferrin. Okay, so this Fe3 plus form of iron is bound. Okay, this Fe3 plus form of iron is bound with plasma transferrin. Transferrin is a plasma protein. It bonds with the iron, and this transferrin transfers the iron to the liver. Okay, so here in the liver, the iron, it is stored. Which form of iron is stored? Fe3 plus form of iron is stored along with a protein. Okay, Fe3 plus form of iron is stored along with a protein called as ferritin. Okay, ferritin is the protein which stores the iron, which bounds and like is the storage form of iron, you can say. Okay, the storage form of iron is called as ferritin, you can say. Okay, now question is, if you have enough amount of iron, okay, iron is a very bad thing, it's a free radical. Okay, once iron enters into your body, our body does not have any mechanism to excrete the iron back. Okay, we don't have any specific mechanism to excrete the iron. Iron is not going in the urine. Okay, so you have to be very much cautious when to absorb, how much to absorb. So once you have enough amount of iron in your liver is producing a substance called as hepcidin, acute phase reactant, hepcidin. What this hepcidin will do? Hepcidin inhibits this ferroportin. Hepcidin inhibits the ferroportin, means hepcidin inhibits the uptake of iron into the blood. Okay, not into the enterocyte. Okay, so hepcidin, what it will do? It inhibits the uptake of iron entry into the blood. So these are the important points which I want you to know. So then if the iron is not coming into the blood, where it is getting stored? It can be stored in the cells. It can be stored in the cells, in your gastrointestinal cells. Okay, these are the points which I want you to know regarding iron. What else they will ask you regarding iron is, so which substances increases the iron absorption? Look, this is the iron which you will get from the sources, that is Fe3 plus, which is not absorbed. This is called as a non-heme iron, which is not absorbed. You need to convert this Fe3 plus form of iron into Fe2 plus form of iron. For that you require acid. So acid helps in absorption of iron, true. Next, one more acid which is called as ascorbic acid. Ascorbic acid, vitamin C, helps in the absorption of iron, true. Then who inhibits the iron absorption? Inhibits by milk. Okay, milk or tea, tannates, phytates, Okay, milk, tea contains tannins. Okay, phytates. Next, antacids. Okay, antacids, because you know antacids what they will do, they will decrease the acid. When acid is decreased, iron absorption will be decreased. So in the recent exam, this question has been asked, the tea, okay, tea decreases the iron absorption. Tea decreases the iron absorption, true. Tea, milk, okay, tea, milk, all these substances increases the iron absorption. Okay, next let's discuss about the digestion in the intestines. Now first enzymes which I want to discuss here are the pancreatic secretion. Okay, pancreatic secretions. So pancreas is going to produce which enzymes? Which enzymes will be produced by the pancreas? Look, see the pancreas, the first three letters, what are they? Pan. Pan means complete. Okay, pancytopenia. Okay, complete. Pan means complete, right? So this pancreas, it produces enzymes which cause the complete digestion of all substances. Like there are carbohydrate digesting enzymes, protein digesting enzymes and lipid digesting enzymes. Carbohydrate, protein and lipid digesting enzymes are present in the pancreas, they produce. Okay, pancreas produce these enzymes. For example, look here, carbohydrates are digested with the help of pancreatic amylase. Okay, pancreatic amylase digests carbohydrates. Trypsinogen, chymotrypsinogen, procarboxypeptidase. Okay, trypsinogen, chymotrypsinogen and procarboxypeptidase, they digest proteins. Next, pancreatic lipase and colipase. This is the MCQ. Colipase is produced by pancreas. Procarboxypeptidase is produced by pancreas. Okay, so these enzymes digest carbohydrates, proteins as well as fats. Now the point which I want you to know is, look here, chemotrypsinogen. The meaning of the word ogen means inactive. Zymogens, these are zymogens, inactive enzymes. So chemotrypsinogen and trypsinogen, they are inactive. So what you need to do? You need to convert the trypsinogen into trypsin, which is active form. Who will do that job for you? Enterokinase. Instead of enterokinase, they will use the word enteropeptidase. Enteropeptidase is produced by duodenum. It is produced from where? It is produced from duodenum. So trypsinogen will be converted to trypsin. Do you know what this trypsin will do? Now the trypsin is going to convert chemotrypsinogen into chemotrypsin. So chemotrypsinogen will be converted into chemotrypsin with the help of trypsin. So understood? Trypsin converts chemotrypsinogen into chemotrypsin. Then enterokinase, enterogram is the one which converts trypsinogen into trypsin. Pepsinogen will be converted into pepsin by pepsinogen to pepsin with the help of acid in the stomach. So next, let's talk some important points about the duodenum. See, in the duodenum, there are two types of cells present. Okay, there are two types of cells present which are called as the S cell. Okay, let me take this. Sir, in the duodenum, look here in the duodenum, there are two types of cells present. One is S cell, other is the I cell. S cell and I cell both are present in the duodenum. Now, whenever you eat the food, that acidic chyme, okay, whenever you eat the food, this acidic chyme will be there, right? Okay, partially digested food along with the acid, where it will go? It will go into the duodenum. So this acidic chyme will come into the duodenum and stimulates S cells. Stimulates S cells. Now when the S cell in the duodenum, when it is stimulated, the S cells are going to produce secretin. Now what is the function of the secretin? The function of the secretin is, secretin acts on the pancreas. Through the blood it will come and it will act on the pancreas. Now pancreas, under the influence of secretin, the pancreatic juices are produced, released, which are rich in bicarbonates. So pancreatic juices are released with a rich amount of bicarbonates. So what these bicarbonates will do? These bicarbonates will neutralize the acid in the duodenum. Okay, so it helps with the acid neutralization. So S cells, secretin is antacid cell. Secretin is actually called as nature's antacid. Secretin is the nature's antacid. How it is antacid? Secretin stimulates the pancreas to release more bicarbonate rich pancreatic juices. So bicarbonate neutralize acid. Next, whenever you eat the fat rich food, okay, the fat rich food is going to stimulate the I cells in the duodenum. I cells, what they will release? Cholecystokinin and pancreozymin. Even look, this cholecystokinin and pancreozymin acts on pancreas. Even it acts on pancreas, cholecystokinin and pancreozymin. But when cholecystokinin and pancreozymin, when it acts on pancreas, now pancreas is going to release enzyme rich pancreatic juices. So pancreatic juices are released rich with enzymes because you are eating fat. The fat need to be digested. So what happens is the pancreatic juices become rich with the digestive enzymes. Okay. Not only that, this cholecystokinase pancreosomin is also having one more function. It is also having one more function. What is that? This cholecystokinase pancreosomin acts on the gallbladder, causes the contraction of gallbladder, helps in release of the bile. You know what is the function of the bile? Bile helps in the digestion of fats. Bile helps in the digestion of fats with the process of emulsification. Okay. So these are the two important points about S cells and I cells. Both S cells and I cells are present in the duodenum. What is the stimulus for the S cell? It is a acidic chyme. What is the stimulus for the I cell? It is a fat rich food. S cells produce secretin, that is the nature's antacid. I cells produce cholecystokinin pancreosomin, which is going to cause the contraction of gallbladder, and it is going to make your pancreatic juices rich in enzymes. Okay. Now I want to discuss a few more important points about the bile here. Okay. What are the important points about the bile? Look, where bile is produced, the bile is produced in the liver. How much? 500 ml every day. What are there in the bile? Which digestive enzymes are there in the bile? See, bile does not contain any digestive enzyme. Bile does not have any digestive enzyme. Then what is the role of the bile? See, bile, it's going to convert these large fat molecules. Okay, large fat molecules are difficult to break. Okay, large fat molecules are difficult to digest. So your bile salts which are present in the bile, okay, bile salts and bile acids, both bile acids and bile salts, they will convert this large lipid droplet into smaller droplets. So this process is called as emulsification. So what is emulsification? Emulsification is a conversion of large lipid molecules into smaller droplets. This is called as emulsification, and who is going to do that? Bile acids and bile salts. So in bile, what do you have? Bile acids and bile salts. Not only that, bile pigments are there, bilirubin and biliverdin, bile pigments are there. Cholesterol is present in the dissolved form. Water is there, electrolytes are there, phospholipids are there. Okay, bile acid, bile salts, phospholipids, electrolyte, water, cholesterol. Okay, all these bile pigments, all these things are there. Okay, what is emulsification? Conversion of a large lipid droplet into a smaller droplets is called as emulsification. The point which I want you to know is these bile acids, bile salts, their function is completed. Their function is completed. Now they are again reabsorbed back. Okay, these bile acids and bile salts, they are again taken back into the body. Look here, the bile acids and bile salts are released into the duodenum. Emulsification completed. Their fat digestion completed. Now these bile acids, they are again reuptaken back into the blood, and through the blood they are again coming back into the liver. They are again coming back into the liver. So this is called as entero, means your intestines, entero. Hepatic means your liver. Reuptake. So there is enterohepatic reuptake of bile acids. Okay, enterohepatic reuptake of the bile acids. Now remember, there are certain drugs. Okay, there are certain drugs which will inhibit this reuptake. Okay, if you give that drug, this reuptake will be inhibited. That is called as BABA drugs. Okay, those drugs are called as BABA drugs. So what the BABA drugs are doing? Inhibit the enterohepatic reuptake of bile acids and bile salts. Okay, enterohepatic reuptake leading to the loss of bile acids. Now bile acids are not going to be reabsorbed, they are lost in the feces now. Okay, question to you, say these drugs, what are the examples of drug? Cholestyramine, cholestyramine and cholecyvalam. Cholestyramine, cholecyvalam and cholestyramine, these are all BABA drugs. They inhibit the bile acid reuptake. Okay, you can ask me why? What is the purpose? So you can use these drugs in the treatment of dyslipidemia or hypercholesterolemia. Hypercholesterolemia. Okay, hypercholesterolemia. Why? Because bile acid and bile salt, do you know what are they? They are made out of cholesterol. The bile acid and bile salt, they are made out of the cholesterol. Okay, they are made from the cholesterol. So if I take a BABA drug, I am losing the bile acids and bile salts every day in the feces, which means I am losing the cholesterol out of the body. So cholesterol levels can be brought back to a normal. Okay, they are dyslipidemic drugs. Okay, cholestyramine, cholestyramine and cholecyvalam. Now, certain terminology I want you to know. What is a cholegog? Cholegog. Who is a cholegog? The one who causes the contraction of gallbladder. The one who causes the contraction of gallbladder and helps in the bile release is called as a cholegog. Who is that? Cholecystokinin. So cholecystokinin causes the contraction of gallbladder and helps in the release of bile. That's called as a cholegog. Okay. Now let's talk about a few more things. In your intestines, mucus is produced by goblet cells. You know it. In the recent exam, okay, NEET PG exam, this question was there. Tannic cells produce lysozyme and defensins. This is the question. Defensins are produced by this Tannic cells. Defensin molecules are produced by Tannic cells. They are all antibacterial things. Okay, they are all antibacterial. Next, in your intestines, there are these cells called as Mohs cells. These Mohs cells, they produce a hormone called as a motilin. What is the function of motilin? Motilin causes the contraction of GIT. Motilin causes the contraction of GIT smooth muscles. So, they help in motility. So, motilin increases the gastric and intestinal motility. Gastric motility, that is the stomach motility as well as the intestinal motility. Okay, good. But these motilin receptors, okay, motilin receptors are not only stimulated by the motilin, they are also stimulated by a drug called as erythromycin. So, there is a drug called as erythromycin. It can also, it's an antibacterial thing. So, for example, say imagine I am having some infection, erythromycin, I am taking erythromycin, I am having some infection, I am taking this erythromycin. So, bacteria will be killed. Okay, the problem is solved. But the problem is this erythromycin unnecessarily stimulates the motilin receptors. Motilin receptors are unnecessarily stimulated. So, because of which the patient can have diarrhea. So, that is the side effect of erythromycin. It causes the diarrhea. So, we know one thing now. Now we know this erythromycin, it can increases the GIT contractions. It can increase the GIT contraction. Apart from treating the disease, it can cause the GIT contractions. So, it can be used in people. It can be used in people who are not having contractions. So, for the treatment of diabetic gastric paresis, okay, diabetic gastric paresis or paralytic ileus. So, diabetic gastric paresis and paralytic ileus, in these two conditions, we can use the drug called as erythromycin. In these conditions, we can use erythromycin. Okay, completed. Now, one more hormone, important GIT hormone, which is called as ghrelin. Your intestines produces ghrelin. Now, what is the function of this ghrelin? Ghrelin, it is produced during fasting conditions. Ghrelin is produced during fasting conditions. It increases your hunger. Ghrelin, it increases the hunger. What is the hunger center in the brain? Lateral nucleus. Okay, lateral hypothalamic nucleus is the hunger center. Ghrelin goes and stimulates there. Okay, it's increasing your hunger. And not only that, what is the relationship between ghrelin and insulin? See, ghrelin is there during fasting. During fasting, you are not eating anything. If you are not eating anything, what happened to your insulin levels? Insulin levels decrease. So, ghrelin actually decreases your insulin levels because insulin decreases the blood glucose levels. Ghrelin increases the blood glucose levels. Okay, during fasting condition, you require the glucose. So, you should not have insulin in your body. So, ghrelin increases the insulin. It increases the growth hormone and increases the acid. So, fasting is actually very good. When you do fasting, ghrelin will be produced and it decreases your insulin. The insulin is the number one, like the number one bad guy in the body. It's the one responsible, the hyperinsulinemia is the one responsible for a lot of bad things in the body. So, when you do fasting, the insulin level drops. Okay, the insulin level drops. Body becomes more sensitive to insulin. The higher levels of insulin these days in the bodies is the one which is causing the insulin resistance. Okay, so you are eating too much. Because of more glucose, more insulin is getting produced. Because of the too much hyperinsulinemia, that's the one which is causing the insulin resistance. So, if you do fasting, what happens? Ghrelin is produced. Ghrelin decreases the insulin. Ghrelin increases the growth hormone. Growth hormone have a lot of beneficial things. Okay. Next, ghrelin increases the acid and ghrelin also increases the gastrointestinal motility. Okay, gastric motility and intestinal motility. Look here, it's a motilin increasing the gastrointestinal motility and ghrelin also increases the gastrointestinal motility. If someone asks you who increases the gastrointestinal motility, ghrelin as well as motilin. Okay. Now, after this, the next topic which I want you to know is the GI motility, gastrointestinal motility. Now, I am asking you, your GIT contractions, are they under your control? Your GIT is like smooth muscles. Can you contract the smooth muscles? No, it's not under your control. Then, who is controlling it? Pacemaker cells. Who are these pacemaker cells called as? The pacemaker cells of your GIT are called as interstitial cells of Kajal. Okay, interstitial cells of Kajal. Now, if you look at this interstitial cell of Kajal, this is the interstitial cell of Kajal. In these interstitial cell of Kajal, always the electricity is fluctuating like this. Okay, always the electricity, the resting membrane potential of the cells, it is fluctuating. Okay, so these fluctuations are called as basal electrical rhythm. Okay, these fluctuations are called as what? Basal electrical rhythm. See, these basal electrical rhythm, they are not action potentials. They are not responsible for the GIT contractions. These are just the fluctuations. That's it. Okay, these are just the you can say these are the graded potential, local voltage changes. Okay. So what is happening in this cells? The electricity is fluctuating, increasing, decreasing. But when you actually eat the food, the parasympathetic nervous system is activated. When you eat the food, the parasympathetic neurotransmitters are released onto this interstitial cell of Kajal. So look, now on the basal electrical rhythm, what are you getting? You are getting the spikes. So these spikes are called as spike potentials. These are called as what? SP, spike potential MCQ. These spike potentials, see, whenever spike potentials are coming, now look at the mechanical recording. Now your GIT is contracting. Initially, during the basal electrical rhythm, there is no mechanical recording, no mechanical contraction. But when you are having the spike potentials, now your GIT contractions are happening, mechanical recording is coming. More the number of spikes, more powerful contractions. Okay. Next, when your sympathetic nervous system is activated, sympathetic nervous system, you have to either fight or fly away. This is not the time to cause the GIT peristalsis. This is not the time to use the energy for GIT peristalsis. So, epinephrine, sympathetic neurotransmitter, when it is coming, look at what happened to the spikes. Spikes are gone. So again, automatically your GIT contractions are decreasing. Okay. So the initial waves which you have seen here, these are called as a basal electrical rhythm, also called as slow waves. Okay. Basal electrical rhythm also called as what? Slow waves. And now look carefully. Again I am telling you, basal electrical rhythm, this is not an action potential. They are not going to cause any GIT contractions. Okay. Having said that, they will ask you, what is the rate of basal electrical rhythm? Guys, there are many interstitial cells of Kajal. Okay, there is only one SA node, pacemaker in the heart. There is only one Prebord-Zinger complex, the pacemaker of the respiratory system. But there are many interstitial cells of Kajal. Okay, there are many interstitial cells of Kajal. Now, if you look at this interstitial cell of Kajal, look at here. This is the interstitial cell of Kajal from the duodenum. Now, in this cell, look. Many times the voltage is fluctuating. The basal electrical rhythm, many times it is fluctuating. If you look at the cecal interstitial cell of Kajal, the basal electrical rhythm is very less. Okay, the number of times the electrical voltage fluctuates in a minute, is very less. It's very less, only 2 times here. Okay, here more times, 12 times. So this is the topic of rate of basal electrical rhythm. Say in the duodenum, the BR rate is 12 times. Okay, in a minute, the electrical voltage will fluctuate for 12 times, and in the cecum, the BR is going to be 2 times per minute. So maximum BR is there in the duodenum and minimum BR is there in the cecum. Okay, next, the next topic is the peristalsis and segmentation. Look here guys carefully. What exactly is peristalsis? During peristalsis, you have taken the food. Okay, yes, we have taken the food. Now peristalsis is starting. The proximal segment is contracting. The proximal segment, the first part, to prevent the regurgitation of food. Okay, to prevent the regurgitation of food, the proximal segment is contracting. So the food can't go backwards. There is always aboral. Okay, there is always aboral movement of the food. So the proximal segment is contracted and the distal segment actually relaxes to welcome the food. Okay, so food is moving in one direction. There is a propulsion of the food, forward movement of the food. The question that can come up in your exam is the contraction of this proximal segment is due to which neurotransmitters? Acetylcholine and substance P. Acetylcholine and substance P causes the contraction of the proximal segment, and this distal segment is relaxed. This distension or the dilation of this distal segment, it is due to nitric oxide and vasoactive intestinal peptide, these two. Okay, vasoactive intestinal peptide and nitric oxide are going to cause what? They are going to cause the relaxation. They are going to cause the relaxation of the distal. Now, this is peristalsis. Peristalsis is for the forward movement. It's for the forward movement of the food, for the propulsion of the food. But you look here, okay, this type of GIT contraction is called as a segmentation. In this segmentation, the proximal and distal segments are contracting, dividing in the food into small pockets. Actually, now the food will go forward and backward as well. Now the food will go forward, backward as well, and there is a mixing movements actually. There is what kind of movements? It's a kind of a mixing movement. Okay, so ultimately what is happening to the food? The food is getting digested. So segmentation is a mixing movement. Okay, it's a mixing movement for the digestion. Okay, this peristalsis is for propulsion, forward movement, and segmentation is for digestion. Okay, now after this, let me discuss a few more important points about the migratory motor complex. What is this migratory motor complex? Migratory motor complex means, see, even during fasting states, look, I have told you segmentation and peristalsis. When segmentation and peristalsis are happening, food is there. So that is the segmentation and peristalsis, they happen during, okay, they all happen during fed state. Okay, so peristalsis and segmentation is happening during the fed state. You have taken the food, but even without food in your stomach, even without food, the GIT will contract. So that is migratory motor complex. When it is seen during fasting state, now the contractions are starting from the stomach to the colon. Okay, the contraction is starting from where to where? Stomach to the colon. What these contractions are doing? What exactly are they doing? See, they clean the GIT. Okay, these contractions, they are cleaning the leftover particles. If there is any leftover particle, that should be cleaned. Okay, that should be cleaned. So this migratory motor complex, it cleans your GIT. So that's why it is called as a broomstick of GIT or sweeper of the GIT. Broomstick of the GIT, homekeeper of the GIT, sweeper of the GIT. Okay, what it is doing? It prepares your GIT for the next meal. Like it cleans your GIT and prepares your GIT. Migratory motor complex, it is starting with the letter M. So the point which I want you to know is the migratory motor complex is mediated by which hormone? Motility. Okay, migratory motor complex is mediated by motility. And how frequently you will get this migratory motor complex? How frequently you will get these waves? Okay, for every 1.5 hours. One migratory motor complex is going to be seen for every 90 minutes. For every 90 minutes, one migratory motor complex is going to be seen. Okay, so these are some important points which I want you to know for your exams. Look at here, the motility in your GIT. You know, there is electrical motility, electrical fluctuation, that is called as a basal electrical rhythm, and real mechanical motility, mechanical contractions. During fed state, you will have peristalsis and segmentation, and during fasting state, you will have migratory motor complex. So with this, we have completed the concepts. Okay, we have completed the concepts which you need to know for your exams. After this, now let's discuss some important MCQs. Which of the subsequent pairs are incorrectly matched? Okay, incorrectly matched. So let's look. Gastrin is produced by G cells, true, in the antrum region. Secretion is produced by S cells in the duodenum. CCK is produced by I cells in the duodenum and jejunum. Okay. Motility is produced by MO cells, not the M cells. This is important. Okay, motility, it is produced by MO cells, Mo cells. Okay, not the M cells. This is the false thing. You know, I have taught you secretion is produced by S cells in the duodenum. Cholecystokinin is produced by the I cells in the duodenum, and not only duodenum but also jejunum. Okay. Next, what is the type of GIT motility shown in this image? So in this image, you can say the proximal segment is contracting and the food is moving in the forward direction towards the anus, always aboral. Okay, this is, you can say, peristalsis. For sure, this is peristalsis, no doubt. Okay. Now look here, histamine is secreted by, you know. So histamine in the stomach, it is produced by enterochromaffin-like cells. Because I have taught you enterochromaffin cells produce serotonin. Enterochromaffin-like cells produce histamine, and what is the function of histamine? Histamine stimulates the release of acid. Okay, histamine stimulates the release of acid. Next, colipase is found in Okay, where do you find this colipase? It is found in pancreatic juices. I have told you pancreatic juices, they produce salivary amylase, they produce pancreatic amylase, trypsinogen, chymotrypsinogen, procarboxypeptidase, pancreatic lipase as well as colipase. So colipase is found in pancreatic juice. Okay. Factors increasing the gastric motility. So who increases the gastric motility? The GED contractions. Who? You already know it. Gastrin increases the gastric motility. GERD increases the gastric motility. Motility increases the gastric motility. Not only them, who else can increase the gastric motility? Is presence of acid in the stomach, distension of the stomach. See, out of all the distension of the stomach here, okay, when you actually eat the food, the distension of the stomach is the one which stimulates the release of acid. It's the distension of stomach which is stimulating the contractions. So this is the answer. Distension of the stomach is one of the important factor for the increase in the motility. Okay. Next, enterokinase is secreted by, I have told you, enterokinase, or they can use the word enteropeptidase. So enterokinase or enteropeptidase is secreted by duodenum. What is the function of this enterokinase? Enterokinase converts, okay, enterokinase, it converts trypsinogen into trypsin. The trypsinogen will be converted into trypsin with the help of enterokinase. Next, our human physiology is designed to detect the harmful substances through the perception of bitterness. Say, we know what is good and what is bad. Okay, when you take something bitter, when you taste something bitter, you are definitely going to spit it out, thinking that this is something not good in taste. Okay, this is actually something bad to our body. Okay, so this bitterness is due to the presence of alkali substances, alkaloids. Okay, alkali substances. So hydrogen ions are going to give you the acidic. Hydrogen ions are the acids, they will give you the sour taste. Okay, they will give you the sour taste, but alkaloids are going to give you the bitter taste. Carbohydrates are going to give you the sweet taste. Okay, sodium chloride is going to give you the salty taste. Okay, next, which of the following reflexes? Okay, which of the following reflexes? Gastric emptying is delayed when acidic content enters the duodenum. Okay, look here carefully. Here is the stomach, here is the duodenum. When acid comes into the duodenum, that inhibits the gastric emptying, delays the gastric emptying. Okay, this is called as enterogastric reflex. Okay, enterogastric reflex. It's the intestines telling the stomach, stop. Enough food came, let it digest, let it absorb. Otherwise, if all the food enters into the duodenum at a time, you imagine, if all the food enters into the duodenum at a time, what happens? What happens? There will be immediate rapid sugar spike. Okay, there will be glucose spike in the blood. That's not good for the body. So there should be little by little movement of the food from the stomach into the duodenum, and that will happen with the help of enterogastric reflex. Okay, so that is enterogastric reflex. Okay, next, which are the following? Okay, for example, let's say following a complete ileal and partial jejunal resection. Maybe the person is having a cancer or because of some other reason. Now you have removed ileum, complete ileum is gone and a partial jejunum is gone. Now it's very clear, I have told you in the ileum region, in the ileum, okay, in the ileum, who is absorbed? It is the vitamin B12 which is absorbed. Okay, who is absorbed in the jejunum? The folic acid. So now when you remove the ileum, vitamin B12 absorption is not going to happen. That is going to cause the vitamin B12 deficiency anemia. So this patient will have vitamin B12 deficiency. Okay. Which neurotransmitter is responsible for the anterograde dilation of the small intestine? I have told you the proximal segment will contract and the distal segment will relax to take the food forward. So the anterograde segment will be dilated. The anterograde dilation is mediated with the help of nitric oxide as well as vasoactive intestinal peptide. Okay, nitric oxide and vasoactive intestinal peptide. Okay, next, liver synthesizes all of the following except. Okay, liver synthesizes all of the following except. Liver synthesizes your albumin, which is responsible for your oncotic pressure. Liver synthesizes your clotting factors, coagulation factors, true. Acute phase reactants are produced, true, but immunoglobulins are not. Your immunoglobulins are the proteins, of course, they are gamma globulins. Immunoglobulins are gamma globulins. These are produced by the plasma cells. The activated B cells, which are called as the plasma cells, they produce the immunoglobulins, but not the liver. Okay, so your immunoglobulins are produced by your plasma cells. Which of the following is not a dietary fiber? Okay, which of the following is not a fiber? See, look here, these complex carbohydrates like cellulose, inulin, pectin, these are all complex carbohydrates. These are all the polymers of, like, the sugar, okay, which are indigestible. You can't digest them. Cellulose is a plant carbohydrate, it's a plant starch, okay. So, cellulose, inulin, pectin, these are all dietary fibers which you can't digest them, which is really good for your body, which is really good for your gut bacteria, but milk is not a fiber, okay, milk is not a fiber. You can look here, see the dietary fiber, see pectin, inulin, cellulose, hemicellulose, lignin, okay, these are all fibers, but milk is not a fiber. Which part of the liver stores vitamin A? Okay, vitamin A is actually stored in the liver. It is ito cells. Okay, ito cells are those cells which stores vitamin A. Okay, next, what is the transporter of iron in the introcytes? I have told you, if this is the lumen, look, if this is the lumen, here iron is there. Which form of iron is absorbed? Fe2 plus form of iron is absorbed. This Fe2 plus form of iron will be taken into the cell with the help of DMT1, divalent metal ion transporter 1, and from the cell the iron will move out, okay, will move out with the help of ferroportin, So entry with the help of DMT1, exit with the help of ferroportin, okay. So its answer is divalent metal ion transporter 1, that's MCQ, okay. So next, slow waves are generated by, you know what exactly are the slow waves? See, slow waves are nothing but the basal electrical rhythm. I have told you basal electrical rhythm, where it is seen? It is seen in the interstitial cells of Kajal. It's the interstitial cells of Kajal, which are the pacemaker cells. These basal electrical rhythms, these are just the electrical fluctuations. These are not the action potentials. They are not contributing to GIT contractions. No GIT contractions, not action potentials. They are not spike potentials. These are just electrical fluctuations. Okay, so they are called as slow waves. Okay, they are called as slow waves. So with this, all the important points what and all need to know for your exam. Okay, they are all completed. Okay, also we have discussed the concepts. Also we have discussed the PYQs in a very short little time. Hope the video is going to be helpful for your exam. See you in the next video. Thank you.